Hi, welcome to Exam Med. I'm Chinmay and today we'll talk about SLE. So first we'll look at the definition. The key points that you need to remember are that it's an autoimmune disease. It affects the organs, tissues and cells by causing cell-mediated damage by autoantibodies and immune complexes. And you can form your sentences around this. Etiopathogenesis is basically the interaction between the environmental factors and the susceptibility genes.
Hi, I'll be voicing over so as to increase the pace of the video. Now let's look at what the environmental factors do. They damage the DNA, leading to cell death, that is apoptosis. Now the cell is broken down into really tiny fragments and parts of the nucleus, such as the DNA, histones, and spliceosomes are exposed, and they are our nuclear antigens.
So let's see what the environmental factors are. First one being the UV radiations. Approximately 70% of the SLE flares is caused by UV radiations. Second is estrogen. As you know, SLE is really common in women, and it's much more common in reproductive age groups. So hence the ratio between women is to men in the reproductive age group is 10:1, whereas the non-reproductive age group is just 2:1. Hence we know estrogen is an important factor. Then we have few drugs like procainamide, isoniazid, and a few bacteria and viruses too. So we would be wondering what are these environmental factors are really common and every human being is exposed to. However, we don't have accumulation of nuclear antigens. Why? That's because it's effectively regulated, or in layman's term, it's just washed off. But in SLE, that's not the case, and that's where our susceptibility genes comes to play.
Remember that SLE is not caused due to the mutation in a single gene, but it's a multigenic disease, mostly in the HLA region class 2 DQDR and class 3. What are the two things that happens? One is there's the production of the antinuclear autoantibodies and the prevention of the effective regulation of the nuclear antigens.
So now let's see what happens. These nuclear antigens and the antinuclear antibodies combine to form an antigen-antibody complex. So now we have the formation of the antigen-antibody complex. This complex gets deposited in organs, tissues and cells and leads to the activation of the complement system causing inflammation. And now that leads to the clinical illness. Remember that it's nothing but a type 3 type of hypersensitivity reaction. So we'll be discussing the clinical features under 11 criteria because that's going to help us in our diagnosis later.
Malar rash is nothing but the erythema over the malar eminences while sparing your nasolabial folds, giving the characteristic butterfly appearance. Remember that malar rash is not pathognomic of SLE and it can be seen in pellagra and Bloom syndrome. Discoid rash is a circular erythematous patch which is depigmented and has an atrophic center. All the dermal appendages over here are lost and it can be quite disfiguring if it's seen on the face or the scalp. One of the common complaints by the patient is photosensitivity, that is, exposure to the sunlight causes rash. Flares of SLE usually can result in oral or nasopharyngeal ulcers. Arthritis is non-erosive and usually involving two or more peripheral joints, usually the wrist joint or the knee joints. Swelling, tenderness, and effusion are seen. Serositis. Pleuritis and pericarditis are the more common forms of serositis. There can be severe life-threatening forms such as myocarditis and Lippensack's endocarditis, which is nothing but fibrinous endocarditis. In renal disorders, the most common is asymptomatic nephritis. On urine analysis, it shows proteinuria and cellular casts. Neurological disorders such as seizures and psychosis are pretty common and they do not have any apparent cause. Cognitive dysfunction can be seen in diffuse lupus. Hematological disorders such as hemolytic anemia is seen. It is normocytic or normochromic type. Lymphopenia, leukopenia, and thrombocytopenia are also the common manifestations. Antinuclear autoantibodies are positive in 95% of the patients. They develop within a year and they can be measured by immunofluorescence and any equivalent tests. In the other 5% of the cases where the ANA is negative, few other antigens such as anti-dsDNA, anti-Smith antigen, and anti-phospholipids can be seen. Anti-dsDNA is usually formed by IgG antibodies. So let's look at the algorithm for our diagnosis. So the patient comes with the symptoms and you order tests such as antinuclear antibodies, complete blood count, and platelets. Now there are three possibilities that can happen. The first scenario being the tests are normal and the symptoms subside. The second one being the tests are normal but the symptoms still persist. And the third scenario being the tests are abnormal. So when the tests, first scenario where the tests are normal and the symptoms subside is definitely not SLE. In the second scenario where the tests are normal and symptoms persist, we order tests such as anti-dsDNA, anti-Smith antigen, and repeat ANA. Now there are two possibilities. All these tests can come negative, and if they're negative, it's again not SLE. And if they're positive, there are two things that can happen. It's either definite SLE or possible SLE. Remember when I said our clinical features will help in our diagnosis? If more than 4 of those symptoms are seen at any given point, it's definite. And if less than 4 is seen, it's possible.
The treatment is based on whether it's life-threatening or not life-threatening. If it is not life-threatening, we'll stick to a conservative management. Or if it's life-threatening, we'll go with the aggressive treatment. So let's see what's our conservative management. We use analgesics like aspirin in high doses to relieve the pain, but there's several side effects and they're pretty severe like aseptic meningitis. Then we have antimalarials like chloroquine, which reduces the flares and dermatitis, but they also cause retinal toxicity. But what if the quality of life is still bad? Then we might use some low dose glucocorticoids like prednisolone. But you know what are the side effects of using glucocorticoids. So aggressive. What if it's aggressive? We use high doses of systemic glucocorticoids like methylprednisolone and cytotoxic drugs like cyclophosphamide and azotriazolam to control the acidity. Hope you liked the video and please like, share and subscribe. Thank you.